Hello, everybody. Thanks so much for joining us for Grand Rounds today. And thanks, it's my pleasure to get to introduce and to finally meet Dr. Ann Maitland, who I think I referred to many years ago when we were both working up in Yonkers. She's an assistant professor here in the Department of Medicine in the Division of Allergy and Clinical Immunology at the Icahn School of Medicine at Mount Sinai. She's also the medical director for comprehensive allergy and asthma care in New York and an attending physician and asthma and allergy and immunology specialist at the Metrodora Institute in Salt Lake City. We are delighted to have her with us today to talk about anaphylaxis and mast cell activation syndrome or something else. Dr.
Perfect.
Maitland.
Well,
Right.
thank you for this wonderful invitation. It's always good to connect with fellow community in the Mount Sinai healthcare system. And we're going to be talking about something that actually, when I started in medical school, was considered a rare phenomena. You hardly heard about anaphylaxis, but I have to tell you, the latest statistics shows that 1 out of 50 Americans have been treated for anaphylaxis in this country. And then I also want to talk about the new kid on the block, mast cell activation syndrome, which was just coined in 2010. And a lot of patients are finding Dr. Google and trying to diagnose what their symptoms are contributing. And as it turns out, my job is to figure out, is this an immune disorder forward, or is the immune system responding to something else that might be causing them to have constitutional symptoms like pain syndromes and fatigue? I have these conflicts of interest, which really will not pertain to this conversation. And what we're going to be starting with, this was a great article that was in the Journal of Allergy and Clinical Immunology, just talking about anaphylaxis, mastocytosis, or something else. So I figured this would be a good way to kind of segue into the growing epidemic of hypersensitivity disorders. So first, we're going to talk about the burden of immediate hypersensitivity disorders, such as mast cell activation syndrome, or MCAS, as well as anaphylaxis. Let's talk about the characteristics of these immune hypersensitivity disorders, and understand that mast cells and other immune cells that can cause hypersensitivity disorders sometimes don't do this on their own and can mimic other conditions. And then lastly, how can you diagnose whether or not it is the immune system causing their issues, or is there something else? So I'm going to take us back to the fact that, the term immune system only came into existence in the late 1800s, early 1900s, thanks to the work of early scientists such as Pasteur, Ehrlich, Metchnikoff, and von Behring. And they basically coined the immune system to say, this is how we protect ourselves against microorganisms that were contributing to major more forms of morbidity and mortality back in the late 19th century. And in many ways, once they were using all these blood factors, many of these scientists felt that really the immune system is only to protect us, and there's no way it can cause harm. And so, except for this one gentleman who was a pediatric resident in the Kinder Clinic in Vienna, and he looked at different lesions of individuals that had certain infections, and it wasn't always the same. So he determined that the immune system has the capacity to be allergy, meaning it has the ability to cause change. And the change could lead to protective immunity, or it could lead to hypersensitivity, or both. And I would have to say this was followed up with work by Portier and Richet, who were trying to build on the vaccinations to build protection. And they actually took venom from the Portuguese man of war, injected into dogs. Instead of causing protection, they saw that the immune system would actually cause anaphylaxis in the dogs, and some of them would actually die. So here you have the immune system actually not protecting but causing damage. And the mechanisms that were underlying these hypersensitivity reactions really were not thought about, at least for another 90 years. So along the way, as we started to industrialize our living arrangements and our delivery of healthcare, you saw some amazing medical milestones, like the introduction of antibiotics, the thought that germs could cause disease, the role of sanitation, the concept of an immune system, and vaccines. You saw major forms of death that was from infections essentially go away. And this was captured in an article in 2002 showing that these interventions led to reduction in hepatitis, tuberculosis, measles, mumps, rubella, diphtheria, and streptococcus pneumoniae infections. But at the same time, by 1950, we started seeing a huge increase in both immediate and delayed hypersensitivity reactions. And I'm just going to briefly describe immediate hypersensitivity reactions as you have an exposure and you have an issue within minutes to hours after that exposure. Delayed hypersensitivity disease really focuses on the adaptive immune system and the development of either autoreactive B cells or T cells that are causing damage in various organ systems in the body. So let's kind of drill down on immediate hypersensitivity disorders. And I have to tell you, when I was in medical school, starting in 1989, if you saw somebody with an elevated serum Ig level, you weren't worried about allergies, you were worried about parasites. And in less than 20 years, it's completely flipped. And now, by 2010, this is a little bit old data, but 1 out of 5 of us are at risk for developing urticaria, and 10% of those are at risk for developing chronic urticaria. Rhinitis affects 1 out of 3 of us, with the latest data showing that 1 out of 3 Americans have at least one positive allergy test. Food allergies on the rise, with increasing sensitivity to more foods. Before it was the big 6, now it's the big 8, including sesame. Asthma is underestimated. We guess from the amount of prescriptions and hospitalizations and but we don't screen for asthma, even though 1 out of 10 are thought to have it. And in some communities, especially where you practice, maybe 1 out of 5 or 1 out of 6. Drug allergies are on the rise. Now it's anticipated about like 8 to 12% of the US population have issues with medications, especially the biologics, which are being used and increasing use for not only cancer, but hypersensitivity disorders such as lupus, psoriatic arthritis, as well as multiple sclerosis. And then again, the most concerning thing is 1 out of 50 Americans have been treated for anaphylaxis in this country. So let's talk a little bit about anaphylaxis. This was an article that came out in 2014. And I have to tell you, there's a little bit of confusion on what anaphylaxis is, which leads to underdiagnosis and under treatment. But it's basically generalized mucocutaneous involvement or multi-organ system involvement as demonstrated in this cartoon. It can be triggered by both allergic and non-allergic triggers. Cells besides mast cells have been implicated, including basophils and macrophages. Once rare, but now nearly 2% of us have been impacted by anaphylaxis. And then I would have to say, looking at data coming out of the emergency department, children and adults that have been experiencing symptoms for anaphylaxis are typically underdiagnosed and undertreated. And I want to give this example. This was actually, I was in the emergency department in Westchester with my mother who had influenza A. And I was not going to leave her bedside because you can see, as I'm sure you might have experienced around that time, there are a lot of beds in the emergency department going out the door. And I happened to be standing next to this gentleman who's a resident talking to this young lady who just got transferred from from her dentist's office via ambulance to the emergency department. And she's like, I don't know what was happening. I started to wheeze, I started to itch, I didn't feel well. They gave me Benadryl and called the ambulance because they weren't able to control it. And basically he had assessed her and basically said, well, you just need to avoid what you had, and did not do a referral to an allergy immunology specialist, did not give her an EpiPen. And of course, me overhearing this, went up to him and identified myself and then said, you have like 8 allergy immunology specialists in this practice. She needs to be referred. You just can't do that. And so this is common in the emergency department where patients typically present. So what is anaphylaxis? And I borrowed this term from this recent article by another allergy immunology specialist, including Julie Wang, who's at Mount Sinai. Basically, one person that likened it to anaphylaxis to Justice Potter Stewart's definition of pornography. Basically, I can't define it, but I know it when I see it. Well, unfortunately, a lot of us see it, but not necessarily know that this is multi-organ system involvement. And a lot of it has to do with, there really has been no clear definition of anaphylaxis. There are several diagnostic codes and you definitely don't know how to use it. And then also there's lack of point of care testing. Unlike cardiac attacks, or asthma attacks, we don't have any consistent markers that are readily available in the emergency department to help with the diagnosis. Also, this is a very heterogeneous disorder regarding the array of triggers that can cause this hypersensitivity reaction. Again, mast cells are not the only ones that are involved in anaphylaxis. And then timing. We have some individuals that will have immediate hypersensitivity reactions, or somebody who has alpha-gal sensitivity, which is meat allergy, where they won't experience anaphylaxis till hours after digesting mammalian meat. And then also there are a lot of syndromes that can mimic anaphylaxis as well. So this is now the consensus expert proposal that we have for anaphylaxis, that it is a serious allergic reaction, can involve any of the organ systems. I have a tendency to say that we have a tendency to focus on skin, respiratory, GI, or cardiovascular. A lot of patients will complain about impending sense of doom or have a change in cognition, and sometimes that's attributed to other diseases other than the anaphylactic event. And then there are gynecological manifestations as well, including uterine cramps. And so sometimes the criteria will include neurological and gynecological issues or urological issues, and sometimes not. There are 3 different proposals to say you might be having anaphylaxis again. Are you having skin involvement, mucosal involvement, along with cardiovascular respiratory involvement? Or you have 2 more organ systems that are involved, or you have a drop in blood pressure within known exposure of a trigger. And then there's also a variety of severity of anaphylactic events. I've had for years cold-induced urticaria, which morphed into exercise-induced urticaria. And I found out I had a grade 1 anaphylactic event that I was able to get away with just using histamine blockade. But you can see that depending on when you're starting to have cardiovascular or respiratory involvement, the severity is much higher, where the use of epinephrine should be considered right away. This is just to give you an idea of the various grades. If you have just skin involvement, use histamine blockade and corticosteroids, but be prepared for epinephrine because they can progress. But if you have any involvement with upper airway inflammation, respiratory distress, or cardiovascular distress, or loss of consciousness, epinephrine is the go-to treatment. This is an action plan that all patients receive from me if they have been diagnosed or suspected for being at risk for anaphylaxis. Name whether they have asthma or not, which puts them at a higher risk for having a more severe outcome within exposure. And then they're told what they're supposed to do. Epi is first, not diphenhydramine, not Benadryl, not corticosteroids. You use epinephrine unless there's a reason not to. This is a little bit of an issue with patients that are on beta blockers for migraine headaches or cardiovascular disease. So this is definitely a conversation to have with their cardiologist or primary care in order to coordinate care. And then we have other medications that can be used, including H1 and H2 blockers, as well as corticosteroids. So this is an article talking about new anaphylaxis back in 1991. This is again estimated, and we had no idea about the estimate in the outpatient or ambulatory setting, but 1 in 3,000 inpatients were thought to be at risk or have been treated for anaphylaxis. And you can see there are a variety of triggers in the inpatient setting, especially with individuals who are undergoing dialysis or having administered medications such as antibiotics or pain relievers. This is more recent to show that anaphylaxis, again, is now affecting at least, if you get in a room of 100 people, at least 2 have been treated for anaphylaxis, and many more are carrying epinephrine auto-injectors. And the biggest cause that's associated with that, in addition to a growing number of individuals that have food sensitivities, we have a huge amount of biologics, which are very big molecules that can also be known to trigger anaphylaxis. And then also you have to look at the use of vaccines, including more recently coronavirus vaccines, as well as influenza vaccines. So I wanted to talk about the fact that, again, not all forms of anaphylaxis is due to mast cells. Basophils, which are their blood-borne cousins, have immunoglobulin E receptors, as well as complement receptors. But the one that's very interesting is this, where you have no release of histamine, no release of tryptase. This has nothing to do with mast cells. This is a conversation between macrophages, monocytes, and T cells, which we see in individuals that are receiving chemotherapy for oncologic processes or for infectious processes as well. And just like mast cell, just like anaphylaxis that is associated with mast cells or basophils, this is something that is amenable to epinephrine to stabilize them regarding their cardiovascular respiratory status. So this is just a reminder that mast cells isn't just about histamine. They have chemical mediators, including tumor necrosis factor. I actually treated a patient when I was a resident who had anaphylaxis to a non-steroidal and went into disseminated intravascular coagulation. Mast cells have the ability to release both heparin and platelet activating factor, which is a way that they can alter blood flow depending on what trigger has been seen and what location the encounter had occurred. I just wanted to kind of go over conditions that are known to mimic anaphylaxis, including flushing syndromes. We actually had someone who had a pheochromocytoma that was causing their flushing and labile blood pressure. Red man syndrome when receiving vancomycin. And then you have individuals that actually do have panic attacks, and that can look like an anaphylactic reaction as well. And then the globus sensation, we find in individuals, and especially I'm taking care of patients that have cervical spine issues. Sometimes that globus sensation isn't actually swelling. That is actually the cervical spine pushing up against the esophagus, which makes them feel like their throat is closing. So I just wanted to go briefly. This is not something for you to memorize. I just want to show you how complicated it is to identify whether or not somebody has anaphylaxis or something else. So you definitely start with their signs and symptoms, see if there's anything regarding a history that would be worrisome for a known trigger. Do they have stigmata for a hypersensitivity reaction, such as urticaria, angioedema, or wheezing? If there is a history of a trigger, you definitely want to go ahead and see whether or not allergy testing might identify a likely suspect. If it's positive, you have a way of having various tailored management. If it's negative, you might want to consider a provocation test. For instance, somebody who received an antibiotic in the dentist's office and they went ahead and had a reaction. Was this really antibiotic allergy, or do we need to do a provocation test to see whether or not that's responsible for that? If no trigger is identified, the one thing I would say, if you have somebody who has a history worrisome for anaphylaxis, please check a tryptase. I can't tell you how long it took me to get the emergency department to have this as a ready test for individuals that come through Mount Sinai's emergency department, but this will be very helpful for subsequent evaluations. If they have an elevated tryptase, then you need to evaluate for the possibility of 2 genetic mast cell disorders, including systemic mastocytosis. And I'll get into more details about the more recently identified hereditary alpha tryptosemia. But we check tryptase like you might check individuals who are getting a rule out for cardiac ischemia. We check it with a baseline, we check it within 4 hours of the insult, and then we check it again 24 hours after the resolution of the event. And if it goes back down, you're talking about somebody who has twitchy mast cells, but don't have evidence of a clonal disorder. And so some of them, again, might have alpha-gal, which requires, that's the meat allergy, requires special testing. They actually still may have systemic mastocytosis, but the tryptase wasn't informative. And then we have some individuals that have food-induced anaphylaxis, including individuals that have exercise-induced anaphylaxis. And then if there's a normal tryptase, and it's been checked on many times, there are other validated markers that act as surrogate markers for anaphylaxis. And also we look for the possibility of a neuroendocrine issue that may be contributing to that. If all of that is negative, it's important to think that there might be another diagnosis that would explain those symptoms. So, takeaway. Is it anaphylaxis? How severe was it? Treat, check a tryptase, and send out for an allergist. And again, anaphylaxis can present with any of these symptoms as depicted in the cartoon with the mannequin. So let's move over to the more recent diagnosis of mast cell activation syndrome. And I can't tell you how many individuals have come through my office claiming I have mast cell. I try not to have post-traumatic when I hear that term. But I have to tell you what happened is we started to identify the relationship between IgE and mast cells in 1989. So although mast cells were first described in the late 1800s, the first anaphylaxis was described in 1901. The relationship between anaphylaxis and mast cells was only described in 1989 when they showed the relationship of IgE to binding the high affinity receptor on mast cells as well as basophils. Since that time, for the next 20 years, this is what I did when I was working in Yonkers with ENT and Allergy Associates, we would skin test. And basically, according to the allergist, either it was allergy or not. But I would say by 2010, after I had been working in Yonkers for 5 years, I started to see a growing number of patients, especially female, who were having hypersensitivity reactions, and the allergy testing wasn't explaining it. I just want to show you the difference between an allergen versus an irritant. If I took Clorox and put it on your skin, you're going to have a reaction. But if I take an allergen that you might have an IgE molecule to, if I dilute that allergen down to 1 to 10,000, you still have a significant response. This is how potent IgE is in triggering mast cell and basophil degranulation, causing these various events. And I have to tell you, when I was covering an allergist in the Bronx, every 1 or 2 months, I would skin test somebody and they would go into anaphylaxis from the skin testing. So for years, it was history, allergy tests. Do you want allergy shots? Repeat. But then I realized that, there are a growing number of patients who were still reacting and no allergies. And I wanted to give you an example of the patient where I really had to open my eyes. This was a 4-year-old boy. I was the 11th allergy immunology specialist that he had met. He had been seen by several children's hospital allergy immunology experts who basically said, this is not milk allergy, this is not food allergy, we don't know what you have, but still his diet was limited. He had been treated for anaphylaxis in the emergency department or his pediatrician's office 4 different times. He also had pain, fatigue, and again, these above mentioned allergic reactions. And it's sad, at 4 years of age, he had seen over 20 practitioners without an answer. So what could be the potential etiology of Sean's reactions? And I, said self. What can do this? And there's only 2 cell populations that I know that can cause this type of immediate reactions to encounters, and that are mast cells and nerves. And this is just to show you allergy testing is pretty benign. It could either be done on the back or on the arms. And then you can readily get immunocap testing, and his was all negative. Matter of fact, his Ig level was less than 10. And I wanted to show you, I actually ran a case series. This is something that we had published in 2013. These are all individuals that had recurrent immediate hypersensitivity reactions. They all improved with the use of medications that target mast cells or mast cell mediators. Their tryptase was really unremarkable, and other diseases were ruled out except for a heritable disorder of connective tissue. All of these individuals either had hypermobile spectrum disorder or hypermobile Ehlers-Danlos syndrome. So I wasn't the only one seeing this. The work group in Europe also put together a consensus talking about, instead of just looking for the triggers, why don't we see whether or not it is a cell that is not found in the blood, but based in the tissue at every exposure, any site in the body that's exposed to the environment. So you're talking about the respiratory tract, the genital urinary tract, the skin, as well as the gastrointestinal tract that need to be guarded 24/7. And again, mast cells have substances other than histamine. They have the ability to, these chemicals have the ability to act at various organ systems. And there's always seems to be some involvement of one of the epithelial borders that were involved. This is just again to show you the burden of hypersensitivity disorders. Again, quite common. Matter of fact, I would say before COVID, the epidemic of choice was a hypersensitivity disease. This is just this, and how I started to think about, for instance, his flushing and hives is I know that they're both non-allergic and allergic triggers, identifying different receptors that are on mast cells. We know that mast cells have the ability to recognize complement. They have the ability to recognize IgG binding. They have the ability to recognize T cells. And they also have direct communication with the somatosensory nervous system. This is what I was taught when I was in medical school, IgE and mast cells. This is the number of receptors that have been identified on mast cells up to this point in time. And the one that I think was really important, which we're starting going to hear more for, is this MERG receptor for short. This is what recognizes fluoroquinolones, anesthetic agents that can cause immediate degranulation of these cells. And we see this in the perioperative setting. And we also see this in the ambulatory setting, especially in orthopedics, where they're giving them fluoroquinolones or pain medications, and they're triggering anaphylactic reactions or mast cell activation events. You have the IgE receptor, you have the growth factor that is implicated in systemic mastocytosis. You have toll-like receptors. So I've actually had individuals that have been exposed to coronavirus and had urticaria and asthma. Understand toll-like receptors have the ability to recognize a variety of pathogens as well. You have the opioid receptor, so this is why it might be an issue for some patients taking pain relievers. And then here's the female effect. Going in or out of their menstrual cycle, you have cycling estrogen and progesterone, which will influence the activity and degranulation secretion patterns of mast cells. So rather than think about the triggers, let's see whether or not mast cells are acting up or not. So the diagnosis of mast cell activation syndrome is a rule of 3. Do you have 2 or more organ systems involved, whether they're skin and gut, brain, including brain fog and joint pain, gastrointestinal distress, or what's really difficult to diagnose, interstitial cystitis in patients. So if they have 2 of these, you should start thinking about the possibility of mast cell activation syndrome. Do they get better with medications? And patients are trying things that they can find over the counter very readily. So we know that H1 and H2 blockers are readily available. Nasal chrome for the nose is available over the counter. Omalizumab is an anti-IgE molecule that's used now for chronic urticaria as well as asthma. And ketotifen, which is available as an eye drop, but is also used for hypersensitivity disorders that involve mast cell deactivation. So this is getting a good story. Now the question is, what data do I have to support that it's the mast cells that are driving bus in these reactions? So the gold standard method is tryptase, but you can see that there are other surrogate markers. But I also want to emphasize mast cells are not really found in the blood that you can see. So really, if you really want to understand whether or not someone has mast cell dysregulation, you need to look in the tissue. The first cohort to describe mast cell activation syndrome actually, again, was a joint effort between Allergy, Immunology, and Gastroenterology. They went into an irritable bowel syndrome clinic, where the average patient in this study was in the IBS clinic for at least 5 to 7 years. And they simply asked, do you have symptoms outside of the gastrointestinal tract? And what was really interesting, besides GI distress, it was skin and neurocognitive issues that were the main presenting symptoms for these patients. And this is the questionnaire that I use, and I'm happy to provide this to you, but this is what my patients have to deal with before I see me. I'm like, please just tell me, have you been treated or have you experienced these symptoms? And if they can't check 2 of these boxes, then I'm worried that this might be a mast cell activation disorder. And then interestingly enough, I always ask, do you carry an epinephrine autoinjector? Have you been prescribed or have you ever been treated for anaphylaxis? Here are the medications typically used. I focus on the ones that go for reducing the symptoms, not reducing the burden that might be accompanied with a systemic mast cell disorder like mastocytosis. What was really interesting is all these 18 patients that were identified who had been in the IBS clinic for 5 to 7 years, they all got put on a combination of H1, H2 blockade, and 75% of them reported complete or moderate remission of their symptoms. No one did not react to it. So if you do the appropriate testing and get them on the appropriate medical regimen, their symptoms came under control. Interestingly enough, this was supposed to be a reversal, and they wanted to put them back on their old medications, and most of the patients refused because this is the first time that they had felt well in years. As far as markers, again, you want to get a baseline serum tryptase. So every patient that I have, they have a script. So if they have an event and they end up in the emergency department or urgent care, it should be another tryptase should be drawn. So if it goes up 1.2 plus 2, that's suggestive of twitchy mast cells. Surrogate markers include urine prostaglandins, metabolites, as well as 24 urine collection for for methylhistamine. So what do mast cells look like? It's not like we're doing eosinophilic esophagitis issues. It's not just counting them. It's what do they look like? Normal mast cells are isolated and round. Activated mast cells are spindle-shaped and clustered. So this is normal. This is not normal. So when you see more than a few mast cells starting to cluster, they're being activated. And this is an individual that actually has systemic mastocytosis. So the new diagnosis, the most recent genetic mast cell diagnosis came out of Josh Milner's lab when he was at NIH, who now is the division chief for allergy immunology at Columbia Presbyterian. And he found a genetic disorder that predisposed people to hypersensitivity disorders. This is a gain of function in the enzyme tryptase. It's made of two components. And these families, which is autosomal dominant inherited, have an increased copy number of the tryptase gene. So basically they go from a Saturday night special to a Magnum 45 when the mast cells are triggered. And what was really interesting is they had a trifecta. They had connective tissue symptoms that were worrisome for hypermobility syndrome. They had autonomic dysfunction, including POTS, and they also had mast cell activation events. So here you have a mutation in the mast cells that's responsible for causing connective tissue issues, autonomic dysfunction, as well as immune hypersensitivity. And what's really interesting is this gene exists in at least 7% of the Western European descent Caucasian population. We don't have as much data in other populations at this time. But what I also wanted to show you is it's not about 15, it's about how many clusters. And this is an individual that doesn't have mast cell activation syndrome. This is a patient that has mast cell activation syndrome, but not associated with that tryptase mutation. And this is someone who has mast cell activation in alpha tryptase. And you can see the difference in how many mast cells are clustered in 2s and 3s, and the presence of it as well. So once you've gotten the diagnosis of mast cell activation syndrome, the symptoms are consistent with it. They get better with medicines that target mast cells or mast cell mediators, and you have test results that support it. You need to figure out why these mast cells are misbehaving. Do you have mast cells that have a mutation within, such as mastocytosis or a variant of mastocytosis called monoclonal mast cell activation syndrome? Do they have hyperalpha tryptosemia? And we've seen this with a tryptase level of 8 or higher. And then you have the majority of the patients, mast cells are being driven to release factors due to other comorbid unidentified disorders, such as they have a positive allergy test, or they have meat allergy, or they have an autoimmune process that actually recognizes mast cells and basophils. And then you have this relationship between mast cells and the peripheral neuropathy, or peripheral neurons, where individuals that have vibration-induced urticaria, solar urticaria, aquagenic urticaria, cold urticaria, that is a crosstalk miscommunication between the nerves and the mast cells, thinking that these innocent changes in the external environment triggers mast cell degranulation. The importance of identifying what flavor of mast cell disease you have will also dictate what kind of therapies we have to offer you. So if someone has an undiagnosed immunodeficiency and you're just giving them antihistamines, but they still can't fight off infections, their mast cells are going to jump in to try to help out as best they can. It's kind of the analogy I often tell patients is, you know, if your house is on fire and the police show up, you're not going to be upset about it, but they really can't help you put out the fire. Or when somebody's having anaphylaxis in my office and the first people arrive are the police and the fire department, I'm like, very nice to see you guys, good eye candy, but I need the ambulance to kind of help me there. Just like individuals that have a risk for anaphylaxis, not all patients that have mast activation syndrome are at risk for anaphylaxis, but if they are, we give them precautions saying that there's certain medications for them to avoid. This is what they should do to prevent having a mast cell activation event in the setting of a procedure like receiving dye for an MRI or a CAT scan, or undergoing a dental procedure. And they also have an anaphylaxis plan, so they know what to do if they have a change in health. This is a list that you're going to have available to you, but I just want to let you know that individuals that have mast cell activation syndrome or mast cell activation disease, because I haven't been able to identify lab data to support it, but they still act like it. These are the medications that are considered safe. These are the medications to avoid. So in summary, mast cell activation syndrome is defined by, do you have signs or symptoms, at least 2 or more organ systems? Do you get better with medications that target the mast cells, and what positive lab tests that do you have? And then again, it's also important to rule out anything that might be mimicking mast cell activation, secretion, or degranulation events. I would have to say the most common that I've encountered are individuals that are diagnosed with autonomic dysfunction, such as postural orthostatic tachycardia syndrome. So patients with suspected mast cell activation syndrome often are told that the tryptase is normal, so they don't have it. That's not correct. And I kind of advocate what Dr. Hamilton has advised, who's out of Brigham and Women, who's on that original paper for the first cohort. It's important to keep treating these individuals if they're if they find benefit from the antihistamines, but don't park them on mast cell activation syndrome. Try to figure out why their mast cells are misbehaving so it can lead to more definitive treatments. And I wanted to show you, this is a retrospective study that I had just published last year or 2 years ago. Wow, time flies. Where this is about 980 patients that came through my office in Tarrytown saying, I have mast cell. And so we basically did look back for all the diagnoses, and we found out that 1 out of 5 of these individuals had evidence of mast cell activation disease, hypermobile spectrum disorder, or hypermobile type Ehlers-Danlos syndrome, and they also had an antibody deficiency. So it's really important to try to figure out whether or not some other diseases that can travel and can force the mast cells to jump into the fray, because that's their job. They're supposed to respond to danger. This is a standard panel that's used screening questionnaire to identify individuals that have immunodeficiency. And these are 3 abstracts that I've done through the years showing that individuals who came through complaining about mast cell activation syndrome, we found 17 individuals that had idiopathic CD4 lymphocytopenia. 1 out of 10 had a complement deficiency called mannose binding lectin. And then again, at least 1 out of 5 had evidence of antibody deficiency. I just want to talk about, or just kind of sum up, anaphylaxis versus mast cell activation disease or mast cell activation syndrome. You have anaphylaxis can be due to mast cells misbehaving, basophils misbehaving, macrophages misbehaving. This can happen in individuals that have clonal mast cell disorders such as systemic mastocytosis or monoclonal mast cell activation syndrome, as well as hyperalpha-tryptosemia. Mast cell activation is just talking about aberrant release of chemicals from mast cells and not other cell populations. There can be a range of penetration, even with the genetic disorders, and variable severity from day to day and from year to year. So these individuals need to be followed on a chronic basis and need a medical home with general practitioners, allergy, immunology specialists. If they have mast cell activity, if they have systemic mastocytosis, hematology, oncology, or dermatology needs to be involved as well. Depending on anaphylaxis and mast cell activation disease can be caused triggered by a variety of triggers, both internal, such as changing hormonal cycles, or external triggers such as infections, medications, and even physical triggers. And depending on what is driving the degranulation events, there are a variety of therapies based on the phenotype of their anaphylaxis or their mast cell activation syndrome. Again, it's really important that these patients be prepared. As life goes on, change is going to come, and you want to make sure that they're not going to have an issue if they get a dental procedure or a radiology exam, and that they also should have an anaphylaxis plan just in case. And remember, there's certain medications that they're much safer getting, and there are medications that really should be avoided. Or if they have to get it, you have to pre-medicate them appropriately. And then both for anaphylaxis and mast cell activation syndrome, there are masqueraders. It's important to understand that there are neuroendocrine issues as well as autonomic neuropathy issues that can look like it's anaphylaxis or mast cell activation syndrome. And this is just talking about the different phenotypes that we've already spoke about. I just wanted to let you know that both anaphylaxis and mast cell activation syndrome is a delayed diagnosis with a lot of morbidity. These are just some of the stories regarding delayed diagnosis of mast cell activation syndrome. She's now dependent on IVIG, omalizumab, and IV fluids, as well as a PEG, in order to maintain her nutrition and keep her symptoms under control. Earlier intervention might have prevented that. And then this is just showing that anaphylaxis is routinely underdiagnosed, underreported, and undertreated, especially coming out of the emergency department. So if you encounter a patient in the emergency department that's worrisome for a hypersensitive event, whether anaphylaxis or mast cell activation syndrome, it's important that they be given a prescription for an epinephrine autoinjector unless there's a reason for them not to get it. For some, for instance, we'll give them glucagon injection if they're on a beta blocker. They need education on the offending agent and how to protect against that. And then most of this can be done in allergy immunology specialists, because this is what we've been trained to do and have the time carved out in our schedule to do so. All right. All you need to know regarding anaphylaxis, mast cell activation syndrome, mast activation disease, or mimic masqueraders, until more information to be continued per our next annual meeting. But I have a lot of people to thank, especially the patients. I have to tell you, Mount Sinai has been extremely supportive of these efforts, even though I have a tendency to kind of think outside of the box. Mastocytosis Society, Ehlers-Danlos Society, and Dysautonomia International.
Thank you so much, Dr. Maitland, for that wonderful presentation. So many interesting concepts to think about. I'm sure we have lots of questions, and we have plenty of time. So I will open it up to any questions. You can unmute yourself, or you can send them to me or to the general public in the chat. Or you can ask in the audience as well. I can actually start off with a question while others are thinking. Dr. Maitland, the association between POTS, Ehlers-Danlos, and mast cell activation syndrome sounds extremely unfortunate, I think, both to the patient and I'm sure very frustrating to the physician that has to take on, of course, the unfortunate syndromes. I guess as a primary care doctor and as internal medicine docs, I saw some patients with POTS who were being followed by their neurologist. What can we as primary care physicians kind of look out for to help our patients maybe with the underdiagnosis of mast cell activation syndrome, considering the clinical relationship that you highlighted in your presentation today? Is there anything that we as primary care physicians should think about when we see our POTS patients, taking into account that there is an association with mast cell activation syndrome, and what questions can we ask them to kind of screen them for that syndrome?
So I find that patients have a tendency to focus on what bothers them the most. So they're like, and then you scratch their skin, which is a good way to look for dermatographism. And they're like, oh yeah, this happens to me all the time. And actually, a joint effort between Brigham and Women's Allergy, Immunology, and Neurology department showed that if you have POTS or small fiber neuropathy, and you also have susceptibility to mast cells, inappropriately releasing those chemicals, you have more severe, not well-controlled disease. And so I think it's important that you should screen, again, using that questionnaire. You can just have them check the boxes. You will not get their autonomic dysfunction under control if their immune system is overdrive inappropriately. And so I would recommend screening. Do you have headache disorders? It's amazing what people acclimate down to. And here's the thing, most of these patients are never screened for asthma. So if you're not breathing well, your nerves are not going to be very happy, right? And so that'll also contribute to fatigue. So I have to tell you, every EDS center is a multidiscipline center. The French actually have 3 EDS centers. And they routinely screen for autonomic dysfunction, and they routinely screen for immune dysfunction. A lot of these POTS patients, for instance, have autoantibodies against their nerves. So mast cells and basophils have IgG receptors that can aggravate the autoimmune disease. So I think it's important to screen for, just like if you have somebody who has diabetes, you're going to screen for kidney disease, you're going to screen for cardiac disease and risk for stroke. If you have a POTS patient, I would screen them for mast cell dysfunction, and also I would screen them for hypermobility. And the hypermobility is a pretty straightforward assessment. I'm happy to send that to you. If you're not comfortable in doing that, the easiest thing to do is refer them to somebody who can. This is really a team effort. And you can tell, and by the time they see you, they have check boxes for every single organ system. And literally, I had a patient come to me front and back. This is 2012, 8-point, history, family history, everything she's been through. Turns out she has monoclonal mast activation syndrome, meat allergy, hereditary alpha tryptosemia, and immunodeficiency. So to keep her, and she got Zika when she decided to go hiking up. I'm like, really? So she was, so she was treated by the CDC for the Zika, and she also likes taking care of cats, and she ended up with cat scratch disease. I'm like, so she's maintained on omalizumab, IVIG. She gets targeted physical therapy to help her with her cervical spine instability. And this is honestly, I remember when I was practicing internal medicine, you had 7 minutes. Right? So you really want to identify. So my suggestion is screen and refer out. And I can tell you, I have no problem sending them back to help with their hypertension and their cholesterol issues. And I also, for your female patients, I would strongly screen them for genital urinary issues. A large number of the patients that we see come through, they're complaining about POTS, but they can have pelvic congestion syndrome. They can have endometriosis, which is, again, another diagnosis that takes 1 to 2 decades to diagnose. So I would say early intervention just with screening goes a long way. If you just ask the right questions. And I can tell you, I had one patient who I asked him, do you itch? And his response to me was, that doesn't bother me. I'm like, but that wasn't the question I asked you. So, right. And so try to get them on task. And I have to tell you, I limit the patients. I said, look, understand this is our first meeting. I really need you to tell me the 3 things that bother you the most. It's not as though I'm going to ignore those other things, but I need to bring you back in order to discuss that, because that woman I just told you about, it literally took 10 years to get all of her diagnoses because one of the tests wasn't available until 2017.
Thank you so much, Dr. Maitland. Hopefully, it looks like there's been so much more discovery and information and research efforts to really look into this syndrome and its associated clinical presentation. So hopefully in the next, even 5 years, we'll bring you back, and I'm sure you'll give us a ton of more information to discuss. We do have a couple of more minutes. If anyone has any other questions or comments for Dr. Maitland and her wonderful presentation.
Please screen for asthma. Please screen for asthma. Please screen for asthma. And that could be a questionnaire. There's a 6-question questionnaire that's as effective as getting a spirometry. Understand, we don't know how many, and asthma will aggravate headaches, will aggravate gastrointestinal motility issues, contributes to fatigue. And I can't tell you, I had one woman who literally was sitting in front of me like this. And I'm like, you snore? So upper airway inflammation, and individuals that have chronic upper airway inflammation like sinusitis or allergies, 1/3 of theirs will have asthma. It's just a question of, how bad is it? So there are things that you can screen for just by asking, and then get them plugged in for an evaluation. You don't have to do all of that. I mean, that's the beauty of being in a system like Mount Sinai. You have other practitioners who can do that, do the screen, and then send the information back to you.
Absolutely. I think especially, in New York City, when we have so many environmental triggers, and I'm sure the patient population that we see in New York and the patient population that you see, varies across the United States. So I think it's so important to kind of do the screening, identify, the clinical issue at hand, and then refer out, which I think as a New York physician, you become very, very comfortable with. So thank you for highlighting that, Dr. Maitland.
I'm going to borrow Bill Clinton's comment from the 1990s. If you don't ask, they won't tell you. So definitely do. So perfect.
Okay. Well, if there's no other comments or questions for Dr. Maitland, I'll end it here. Thank you so much, Dr. Maitland, again, for your amazing expertise and for joining us today. It was a pleasure. It was a pleasure learning from you.
Same here. Thank you. And happy spring and Easter and Passover to everybody. Stay in good health.
Thank you so much. Thank you, everyone. Have a great Monday. Bye.